Thank you very much, Pedro, for the invitation to join this very esteemed panel, and thank you to Nestlé for hosting this. I'm going to change the conversation a little bit. I'm probably going to pick up on Pedro's introduction around this being the third wave, the focus on healthy ageing, but I'm going to propose that actually we're moving towards a fourth wave, where we're beginning to talk not just about healthy ageing and functional ability, but well-being. There's never been a better time to think about the issues of healthy ageing and well-being. We're emerging from the devastation of the pandemic and the sort of catabolic crisis that we've lived in as a result of COVID, older people having reduced, disrupted access to services, major deconditioning, which is driving the demand for services. But I'm particularly thoughtful about the impact of that loss of autonomy or agency and the loneliness and isolation as well that has been compounding the physical issues. And of course, we're not through it yet. And we're also facing quite stark economic and consequences of the war in Ukraine, and the issues around fuel poverty are very stark for older people. So there's a lot of public health issues that we need to be considering going forward. There's never been a better time for us to be facing up to identifying frailty, recognising the face of frailty. And thank you, Pedro, for bringing the voices of older people into the session this morning. We need to be identifying frailty not when they come to hospital services or to the outpatient clinic. We need to be identifying frailty where we see it in communities, in primary care certainly, but also before people become dependent on public services. So I think that we need to be moving beyond a focus on healthy ageing and functional ability to a focus on well-being. And the WHO ageing report is very clear on this. Healthy ageing is the process of developing and maintaining the functional ability that enables well-being in older age. Functional ability is not the end point. We need to be doing something with our functional ability to bring meaning and purpose to life. And the 5 domains of functional ability, many of them are impacted by the wider determinants of health, the social factors, poverty, income, social connectedness. And so I'm very conscious that over the conference we've talked a lot about some of the aims of the decade. We've talked a lot about delivering health and care services, attuned and responsive to the needs of older people. And we had a great SIG session last night on long-term care for older people and plans about how we want to focus on that going forward. But are we doing enough around changing how we think, feel and act towards age and ageing? And are we doing enough to ensure that our communities create the conditions and foster the abilities of older people? Fantastic resources that WHO has been producing around integrated care for older people, and they've been highlighted several times in sessions that I've attended at the conference. We've not seen much, though, about the World Health Organization's work on age-friendly communities, age-friendly cities, and the lovely star here that's been adapted from the UK Centre for Ageing Better, all about respect, inclusion, social participation, so many wider aspects to the multidimensional approach that we need to take for older people. As a clinician, I started my journey very much focused on the individual in front of me in the clinic, at the bedside, And I was thinking about the sort of individual case or care management approach. As I matured in my career, I began to think a little bit more about what I could do to prevent them actually getting there, as Stanley was describing. And more recently, working across the whole system, thinking about integrated care models across primary and secondary care and working with community partners. But I think it's only more recently that we're really beginning to get into the territory of what I call population health. And this image from King's Fund, I think, I find very, very useful. That's the space that we really need to amplify and operate within. I was privileged to be part of the European Frailty Prevention Approach Joint Action for 3 years, and I'm really pleased that we took that public health approach to preventing and managing frailty, where we recognise that older people don't live on pathways. They don't live in services. They live in homes with families, social networks, and it's our responsibility to wrap the services around them, not to make them fit our algorithms or our pathways. And so the frailty prevention approach begins to take that sort of population health and public health approach. The work, and I take no credit for this aspect of the work around preventing frailty, the evidence-based review, really focused very much on what you've heard already in the session, although I think we need to go back and rub out those figures and up the protein a bit more, having listened to the talks there. What wasn't there was any reference to the importance of loneliness and social isolation and the impact on the frailty trajectories of individuals. And I think this is one of the landmark papers that we will, I think, see influencing our practice and our research going forward, showing that the negative consequence of loneliness and social isolation are similar to what you would see with a lot of the cardiovascular risk factors. So, are our tools for identifying frailty good enough to think about these holistic dimensions of frailty? Wonderful Rockwood scale that is our, it's the bread and butter of our work. And yet, it's very focused on physical dimensions of frailty. Even citizen-facing tools, which are designed to help older people themselves identify when they're starting to become more dependent, and the life curve is a lovely example of that. Even those are very focused on physical tasks, cutting toenails, doing your shopping, being able to do housework. There's not much about how you feel. Do you feel lonely? Do you feel alone? Do you feel isolated? Do you feel anxious? Do you feel depressed? Wonderful tools that NHS England has to take the credit for, the Electronic Frailty Index. My colleague Andy Clegg and team led the charge on this work, and it's a fantastic tool. But again, very little of the deficits pick up on the emotional, psychological aspects of ageing. There is some reference to social vulnerability within the tool, and it may be that the next version that comes out has that more strengthened. Having said that, it's a very, very useful tool and is well validated against negative outcomes. And we know that we can see the difference in the mild, moderate and severe frailty cohorts. You can segment your practice population or your local community into those different levels of risk. And it's also hugely helpful because the whole point of identifying somebody as being frail is having the opportunity to intervene early and to try and reduce the escalation of dependency. and improve the trajectory of the coming years. And it maps really well, the 4 stages of fit, mild, moderate, severe frailty map really well to the evidence-based interventions that you can then apply to the population, from the healthy ageing advice to the sort of, generally fit and robust population, to more targeted social prescribing referrals to community assets and supports that can help people to manage their health better and to stay connected and involved, so that maintains not just their physical health, but also their emotional and mental well-being. And then the stuff that I think we have really focused on over the conference around comprehensive geriatric assessment and care and support planning and specific targeted interventions for individuals with particular conditions or in particular circumstances. And finally, the more intensive case management of those with very complex and severe or end-of-life care needs. So we know that all of those interventions work. What we struggle with is making it happen on the ground. And that's because we have to take that anticipatory approach to population health and well-being on a place-based basis, and to do it not as an individual clinician, but to do it as a team, and indeed to do it as a cross-sector team. And when we published our paper on what is the integrated care model for frailty, we said essentially it's proactive, personalised, coordinated chronic care. It's gold standard chronic care model alongside excellent access to urgent community response or intermediate care alternatives, because you can have the most Rolls-Royce gold standard chronic care in place in the community, but if you don't have an alternative to hospital admission in the evening or the weekend, then people still come into hospital, and we've heard about the harms that hospitalisation is associated with. And all of that underpinned by a personalised and enabling ethos that supports recovery and independence. And we're now moving to, I think, a future where we very much are talking across the globe around integration of health and social care as a means to deliver value for people, value for professionals, and value for systems. And my own organisation, the International Foundation for Integrated Care, has a really nice, accessible document on the 9 pillars for realising the true value of integrated care. As part of the Advantage work, we looked at lots of international models around around Europe, and many of them have strengths. I'm going to just share a little bit about our own model in Scotland. And I was involved in what we call the Reshaping Care for Older People programme, where we were trying to shift this pathway left. We were trying to shift it from a focus on reactive hospital-based care towards a much more proactive and anticipatory focus in community, and to support some of the enablers of change. I'll talk another time about how that's going. That's definitely a talk for another day. But one of the things that we realise is that you might have the compass, you might have the roadmap, but bringing practitioners, professionals with you on that journey takes time. This is a marathon, not a sprint. And we really need to do much, much more in investing in team-based collaborative practice, particularly in community settings, but also bringing secondary care clinicians together with primary care in extended multidisciplinary teams, and to practice in a very person-centred way, where we start with what matters, and the care and support planning conversation is guided by the older person. Some lovely emerging examples of this in the country, and a shout out for my colleague Anna Talbot, who's here with I think a poster on the work she's doing in Lanarkshire, and also an advert. You have to listen to the presentation from Barcelona at the end of the day in the session with multiple presentations. Two of the most evidence-based interventions that you can do when the team comes together to work in this way is what we call an anticipatory care plan, a thinking ahead plan to discuss future treatment wishes and goals, and also to share that information with colleagues at other parts of the system so that everybody understands what those shared goals are. And the other very important, well evidence-based intervention is a medication review, a structured medication review, and our Scottish model is the 7 steps to reducing inappropriate polypharmacy. The third important intervention is supporting people to help themselves, to understand what they need to do to manage their conditions and to access the whole range of community supports that are out there. But often we as professionals don't know they're there. We don't understand them, so we don't trust them, so we don't use them. So we need to do a lot more about working closely with our community partners. Our community partners, our voluntary sector partners, certainly in the UK and Scotland where I work, they're prolific, they're well funded, and they have not just employed workforce, but they have a fantastic volunteer capacity. So there's lots of work that we can do as geriatricians and as clinicians working with older people to work more closely with our community partners. We also need to have a focus not just on community organisations, but on communities and places and spaces as well, because we know that when you're living in a leafy, green area, the mental health and well-being effects of that are very positive compared to those that are living in less green space. So there's now a growing conversation about the importance of housing places and spaces for older people, not just around assistive living technologies, but around the environment and the well-being impact. And one of my colleagues from Architecture and Design Scotland has come up with the concept of the caring place. And those of you who are familiar with Nolan's census framework for older people might recognise a similarity to some of that sense of worth, sense of purpose, sense of support, and sense of familiarity. There's lots of emerging interest in digital solutions. I heard a lot through the conference about the importance of technology-enabled care. And in Scotland, our digital health and care vision has, at the heart of it, digital information, tools and services I need to help maintain and improve my health and well-being. So not just digital tools to access services or to have treatment, but tools to help me stay well and to get on with my life. But of course, there's a huge issue around digital inclusion, digital poverty that needs to be overcome before that can be really a mainstay of our treatment. And finally, frailty is now emerging as something that is everybody's business. It's the business of every professional, it's the business of social care, it's the business of the third sector community partners. Housing are interested, town planning. Frailty matters. The project we did with community nurses helped us identify what were and if you look at the orange column, what were the key things that they needed to know about for their daily practice. But the green boxes were, what was it that they needed to know to coach and support older people to help themselves? And that led us to a really interesting conversation about well-being. How do you enable well-being in later life? So we looked to the evidence around that, and the evidence around mental well-being is now, over 10 years old, but that wasn't particularly looking at well-being in later life. So the 5 ways to well-being was our starting point, but we then said, okay, let's ask older people what enables well-being in later life. So we did a discovery project that finished in April of this year, and we had 71 older people, organisations and community groups across Scotland who participated, including some of our municipality councillors who were older people champions. It was a great project, really well received, and what they told us was that actually in later life there's 6 ways to well-being, and I think it echoes the conversation around nutrition. They told us that to age well in later life, we needed to have a focus on eating well too. So we had the 5 ways plus eat well, mutually reinforcing, and all of those supported by being embedded within age-friendly, inclusive and compassionate neighbourhoods. And if you want to read more about the outputs of the project, the links are there. So I'd like to conclude just by saying that frailty, preventing and managing frailty is everyone's business. And so we all have a duty to make every conversation, every consultation, and every contact with older people count to create well-being. Thank you.